Hello everyone. So today we will be discussing the part 5 of the revision series of Obs and Gynae. In this we will be discussing labor, third stage, puerperium and their complications. Okay, so let's start it. First of all, we will be discussing about the maternal pelvis. Okay, so you all know maternal pelvis is basically a cavity. As every cavity has, it also has its inlet and outlet. Okay, so the in anteriorly in this cavity is the pubis bone. Okay, anteriorly in this cavity is the pubis bone, and at the back of this cavity there are sacrum bones and coccyx. Okay, so anteriorly of this cavity is the pubis bone. This is a pubis bone, and at the back there is sacrum, and at the last there is coccyx. Okay. Okay, so this is the inlet. Okay, this is the inlet, pelvic inlet, and this is the outlet of the pelvic cavity. Okay, because these are the true inlets and outlets, so they are also known as anatomical inlet and anatomical outlet. Okay, so in NEET PG 22 a question was asked that this area, the one which is shaded, what is this area known as? So now I have to tell you in detail about this cavity, as question can come in our exam also. Okay, so what is this area known as? Now the upper border of this area is the plane of greater dimension. Okay, in this cavity the plane in which the dimensions, the diameters are greater is this plane, this upper red border. Okay, this upper red border of this mid pelvis. Okay, this is a plane of greater dimension, and this plane of greater dimension is goes from upper border of the sacrum, upper border of the pubis up till the S2 S3 junction of the sacrum bones. Okay, so what is the plane of greater dimension from the upper border of the pubis up till S2 S3 junction, and this lower one is the plane of least dimension. This mid pelvis lower plane is the plane of least dimension. Okay, and this goes from lower border of the sacrum up till the S5 and coccyx junction. Okay, so the area which is between the plane of greater dimension and the least dimension is the mid pelvis. So this was asked. Okay, so now one more I am telling you, the area between the anatomical outlet and the plane of least pelvic dimension. Okay, let me change the pen. This area, the one which I am coloring blue. So what is this area? Basically this area is between the plane of, yes, least pelvic dimension and the anatomical outlet. So this area is known as is obstetric outlet. Okay, obstetric outlet. So anatomical outlet, you know, which is the original outlet is the anatomical outlet. And what is obstetric outlet? Obstetric outlet is as such a cavity which is between the plane of least pelvic dimension and the anatomical outlet. Okay, so this was also one of the option, but so I explained it. So now let's go to the another slide. Now the diameters are asked. Okay, first of all we will be discussing the diameter at the inlet of the pelvis. Okay, so as I told you that this is the inlet, right? This upper black line is the inlet of the pelvis. Okay, so this black line, you know, just turned, yes. Now this black line, this upper black line is the anatomical inlet or true inlet. Okay, So this is the anatomical inlet or true inlet. The anteroposterior. Now, as you know that every plane has anteroposterior diameters and transverse diameter. So here we are talking about anteroposterior diameter of the inlet because they are important. Okay, because they are important. Okay, so now this anatomical anterior posterior diameter is known as anatomical conjugate. The interior posterior diameters are known as conjugate. Okay, so the one which is in the black line is known as the anatomical conjugate. Okay, the line, so what is basically the anatomical inlet? It starts from the upper border of the pubic symphysis up till the tip of the sacral promontory. The first sacral vertebra is known as sacral promontory. Okay, so up till the tip of the sacral promontory is the anatomical conjugate. Okay, now this red line, the one which is in the mid of the pubis bone and the tip of the sacral promontory. What is this red line? This is obstetric conjugate. Why it is known as obstetric conjugate? Now conjugate means anterior posterior diameters. And why this red line, the one which is going from the mid of the pubis bone up till the sacral promontory, why this red line is known as obstetric conjugate? Because this is the least in dimension, least in measurement, सबसे कम है तो because it is least in dimension, it has its own obstetric relevance. Okay, so fetus has to go through the pelvis, right? Now the least dimension will become a obstacle for the fetus to pass through, right? So the plane of the anatomical conjugate, and obstetric conjugate is from the mid of the pubis up till the tip of the sacral promontory. And what is diagonal conjugate? From the lower border of the pubis symphysis is to the tip of the sacral promontory, the one which is in the blue line, this one, the one which is from the lower border of the pubic symphysis up till the tip of the sacral promontory. So these are the three conjugate diameters of the inlet of the pelvic cavity. Here I would like to tell you that why diagonal conjugate is known as diagonal conjugate, because we keep our fingers diagonally in the pelvis to measure. If we keep our finger like this, so they are in the diagonal. So what we can measure? We can't measure obstetric, we can't measure anatomical, we can measure diagonal, and this is known as diagonal because we keep our finger diagonally. The mnemonic for this is, if we get confused in the exam, which diameter is which, from down to up, the mnemonic is DOT. D stands for diagonal, O stands for obstetric, and T stands for true or anatomical. Okay, but always remember it is from down to up. Okay, the anatomical conjugate is because we can only measure diagonal conjugate. Okay, so diagonal conjugate is minus diagonal conjugate minus 1 centimeter is anatomical conjugate, and diagonal conjugate minus 1.5 centimeter is obstetric conjugate. Okay, so once again, diagonal conjugate minus 1 centimeter is anatomical conjugate, and diagonal conjugate minus 1.5 centimeter is obstetric conjugate. Okay, so this is equals to 10 point. Normally diagonal conjugate is 12 centimeter, so the anatomical conjugate is 11 centimeter and obstetrical conjugate is 10.5 centimeter. Okay, now we have talked that transverse diameters of inlet are not important, so we are not discussing them in the revision series. We will only discuss the anterior posterior diameters, and all the three are important. Okay, so now we come to the pelvic cavity. In the pelvic cavity, the transverse diameters are important. So now this hole is pelvic cavity. This is inlet, this is outlet, and this hole is pelvic cavity. So which transverse diameter we will take? Yes, which transverse diameter we will take? Yes. Which transverse diameter we will take? The one which is of most important. The most important in the OBS is the one which is the least in dimension. Okay, so now only in the first slide we study the plane of the least dimension, right? So there, why that plane is of least dimension? In the first slide we studied now the plane, the cavity between the plane of the greatest dimension and the plane of least pelvic dimension is known as mid pelvis. So why that plane was of least dimension? Because there was ischial spine. Okay, ischial spine. So so that transverse diameter will be important where there will be ischial spine. So I will color this ischial spine. So these are the ischial spine in the pelvic cavity. So we take the transverse diameter here. So the interischial spine diameter, interspinous diameter, or transverse diameter at the level of the ischial spine, or you can say the most smallest transverse diameter of the pelvic cavity is 10 centimeter. Now what is the relevance of this interspinous diameter? First of all, internal rotation occurs here. Cervical os is at this level. Levator ani is also at this level, and due to that levator ani muscle only the internal rotation takes place, and this is a plane of the least pelvic dimension. It is the plane of least pelvic dimension. As already discussed, station is 0 here. ओके इससे ऊपर होगा तो इट विल बी -1 -2 -3 1 सेंटीमीटर इससे अबव है तो इट विल बी -1 स्टेशन अगर 2 सेंटीमीटर अबव है तो इट विल बी -2 स्टेशन एंड इफ द हेड is below this ischial spine then it will be known as +1 +2 1 centimeter below then it is 1 centimeter. So what is station? Station is the position of the head. If it is at the pelvis, then if it is at the ischial spine, then it is a 0, and if it is above it, then it is minus station, and if it is below it, is the plus station. Now we have studied the pelvic cavity, and we now know that in the pelvic cavity, the transverse diameter, interspinous diameter is only important. Now in the outlet also, now this is an image of the outlet. The transverse diameter is important. The one which is least in dimension we will take, right? So this is the intertuberous, the one which is between the tuberosity. Okay, these are the ischial tuberosities. I think you know this, right? And these are the another ischial tuberosities. So the diameter which is between these tuberosities is known as the bituberous or intertuberous diameter, and it is almost 11 centimeters. So here again the transverse diameter is important. Only in the inlet the anterior posterior or the conjugate diameter was important. In the cavity also the transverse diameter, the interspinous diameter were important, and in the outlet also the transverse diameter is important. And which transverse? Bituberous or intertuberous, the one which is between the ischial tuberosity. Okay, and it is usually 11 centimeter. The diagonal conjugate was 12 centimeter, and the obstetric conjugate was 10.5 centimeter. Interspinous was 10, and the intertuberous diameter is 11 centimeter. Okay. Okay. Now let us see what is contracted pelvis. So all those important diameters which we have studied did. Now if the obstetric conjugate is less than 10 centimeter, then it is a contracted pelvis. If the interspinous diameter is less than 8 centimeter instead of 10 centimeter, if it is less than 8 centimeter, it is a contracted pelvis. And if the bituberous diameter is less than 8 centimeter, it is a contracted pelvis. Okay, I already told you how you will measure obstetric conjugate. You will keep your fingers like this, right? Keep your finger diagonally in the pelvis, right? And you will measure how much of your finger length is involved, and then you will measure the finger length. Okay. So and interspinous diameter, how they are measured, we will put this two finger like this, and we will try to feel the spine. So both of the ischial spine should not be felt simultaneously. Okay, if both are being felt, it means it is a very small in diameter and it is contracted pelvis. And bituberous diameter in the now we are not doing PV, we are just feeling the ischial tuberosity externally, and we are just feeling the ischial tuberosity externally, and we are putting the fist there externally. If our this fist goes, it means it is more than the 8 centimeter and the pelvis is adequate. Okay, now how what is the best method to measure the pelvis? Yes, the best is trial of labor. Okay, if a fetus head is passed of so and so dimension is passed, then it is not a contracted pelvis. The investigating modality which is best is MRI, and at the third number is manual assessment. Please don't mark CT scan in your answers. Many of you have marked in the MCQ practice. Why we will do CT scan? CT scan cause lot of problem, right? Radiation damage is lot and lot, right? So now we will be, after doing the maternal pelvis, now we will be doing the fetal skull. You all know that fetal skull has two fontanelle, anterior fontanelle and the posterior fontanelle. Interior fontanelle, now in the starting only I am telling you, it is quadrangular in shape, and the posterior fontanelle is triangular in shape. Okay, because interior fontanelle is between four bones, two frontal and two parietal, and the posterior fontanelle is between three bone, one occiput and two parietal. So anterior fontanelle is quadrangular in shape and the posterior fontanelle is triangular in shape. Okay, now once we know that this is the interior fontanelle and here is the posterior fontanelle, the area which is between the interior fontanelle and posterior fontanelle, this part is known as the vertex. Okay, and the area which is between the orbits and the interior fontanelle, this part is known as the brow, और जिसे हम फोरहेड या माथा कहते हैं. ठीक है, एंड द वन विच इज बिलो द ब्राउ इज द this part is the face, right? This part is the face presentation, face part. Okay, the one which is below the orbit's edges and up till the chin, this is face. From the brow up till the interior fontanelle, this is from the orbit edges to the interior fontanelle, this is known as brow, and between the interior fontanelle and the posterior fontanelle, this is known as vertex. Okay, now you will remember. Okay, now let us have one slide on skull diameters. So as you all know that skull also will have anterior, posterior and transverse diameter. The anterior posterior diameter, which is the most longest, all is which is the most largest is mento vertical. Vertical is a point between the interior fontanelle and the posterior between here. So it is the most largest and the most common, which in engaging diameter is suboccipito-bregmatic. What is bregma? What is bregma? Bregma is anterior fontanelle. Okay. So suboccipital means below the occiput up till the interior fontanelle here. So this diameter, this interior posterior diameter is suboccipito-bregmatic diameter. So what is bregma? Bregma is anterior fontanelle and subocciput means below occiput. From below occiput up till bregma, the diameter is most common engaging diameter 9.5 centimeter. Okay. Now next is the transverse diameter of the fetal skull. So these are the bimastoid. The one which is at the back of the ear is bimastoid, a little above is temporal, and here the largest diameter is biparietal. Okay, temporal, mastoid and parietal. So here you only have to remember biparietal, and it is 9.5 and it is the largest of all. You can see here that this diameter is largest, then it decreases the most. So biparietal is the largest transverse diameter. Okay, otherwise the most largest interior posterior diameter is the manto vertical. Okay, now what is the lie? What is lie? The relation of the axis of the fetus with respect to the maternal axis is lie. Okay, now if this is fetus and this is maternal axis, what is lie? Longitudinal means both the fetus and the, if this is mother axis, okay, and this is fetus. Now if both are longitudinal, then it is known as longitudinal. If mother is straight and the fetus is like this, it means it is a transverse axis, and if it is like this, it is oblique axis. Okay, so lie means the relation of the axis of the fetus with respect to the axis of the mother. So in the transverse lie, we will always do cesarean. Okay, and we will, it is not that in 36 weeks or in 24 weeks, if transverse lie is there, we will only do cesarean if the transverse lie has got engaged, because after that it is not going to, the lie is not going to change. Okay, once again, and we will do cesarean in transverse lie after the transverse lie has engaged. You all know transverse engagement occurs at 37 weeks around. So if engagement has occurred, then only we will do cesarean, because before that the lie can change. Okay, the lie can change. Now what is presentation? The part of the fetus which is in the lower part of the uterus. Now if this is uterus, okay, the fetus part which is in the lower part, okay, of the uterus is presentation. The presenting, it can be cephalic if the part is head, it can be breech if the part is pelvis. Okay, so what is presentation? Presentation is which part of the fetus is in the lower part of the uterus. Okay, it can be cephalic, it can be breech, it can be shoulder. In transverse lie, usually the presentation is shoulder. So which part is in the lower part of the uterus? Okay, presenting part. What do you understand by presenting part? You know that now we know that for example, if the presentation is cephalic presentation, it means the head is in the lower part of the uterus, which is the most common presentation, cephalic presentation. And now which part of the head is felt on PV? Okay, let me show you in this with the slide. Now for example, now here all are cephalic presentations. right? All are cephalic. Here also it is cephalic, here also it is cephalic, here also it is cephalic, here also it is cephalic. So what we are feeling on PV, see here are what we will feel on PV. Okay, for example, in this case we will feel between the this part, between the anterior fontanelle and posterior fontanelle, this part we will feel. So it means it is the vertex presentation. Here also we will feel between the anterior fontanelle and posterior, so here also the presenting part will be vertex, but here we will feel this part, this is brow, and here will be feeling this part, and this is face. So which part we are feeling on PV is known as the presenting part. Okay, so a cephalic presentation can have vertex, brow and face. Okay, so as we have studied that, what is face? The part in which where nose and lips are there and below the orbital edges. Brow is from the orbital edges up till the anterior fontanelle, or what we say in layman language, forehead. And what is vertex? Between the anterior fontanelle and the posterior fontanelle. Okay, so now what decides, now you can see that in cephalic these are the different presentation. Okay, these are the different presentation. Now what factor is deciding that what presenting part will be there? It depends on the flexion of the neck, which is known as attitude. Okay, attitude. So normally the attitude is flexed like this, fully flexed. Okay, flexed attitude is there, so there the common presenting part will be vertex. So this is the most common of all. Okay, this is the most common of all, right? This is the most common of all. What is happening here? Here the fetus is flexed, okay, and so the presenting part in the flexed attitude will be vertex, and in the presenting part in the extended attitude will be the face. Okay, so if question come, you can do it. Okay, it is simple. You can flex your own head in the exam also. You flex it and at the top you will feel the vertex. You extend it and at the top you will feel the face. Okay, so that's it. So now what is denominator? Next slide is on denominator. What is denominator? The denominator is any fixed point on the presenting part to which can be easily felt and we can easily indicate it. Okay, what is denominator? Now we know what is presenting part. Presenting part is what we are feeling on PV, the part of the presentation which you are feeling on PV, and any part on that presenting part, any fixed point, we will make a fixed point so that we can indicate that for example, if we have to tell where is interior fontanelle, so how we will tell it? So we will tell it in relation to that denominator, that for example in the vertex the denominator is the occiput, and in the face the denominator is mentum. In the vertex the denominator is the occiput. So because occiput is pointed and it can be easily felt, and we can easily tell ki the interior fontanelle is at this much margin, or whatever we have to tell. Okay, so denominator of the vertex is occiput. Denominator means a fixed point on the presenting part to tell the position, to tell all the relevant things about the fetus and fetus. Okay, okay, now what is position? Now you're seeing that here all the fetuses are flexed fetuses, and in all the fetuses the on the PV the vertex is being felt, right? In all this, so all are vertex here, right? But you now see that here the back is in the right position, and here it is in the left position, right? And here the back is in the transverse, and here it is in the right side. So all in, it means the positions of the fetus here all are different. So every presenting part has different positions. So now when we have to tell this position, we will tell it with respect to the pelvis, and where that our denominator is there. For example, the first image, this image, to tell this image, we will do PV. Okay, we will do the PV, and we will see where the occiput is. Now as occiput is in the right part and posteriorly, because anterior part is here, so this is right occiput to posterior. Okay, so let me show you this. See here. Now I already in the starting only I told you that occiput is the posterior fontanelle is triangular in shape, and the interior fontanelle is quadrangular diamond shape, right? So here you can see that the in this, when we are doing PV, the this triangular area is in the front. Okay, the triangular area is in the front, right? And the diamond area is in, so it means in the posterior. So it means anterior part of the fetus is at the posterior, and the posterior part is in the interior. And which part of pelvis is this? Left part, because when patient lies in lithotomy, then it is usually the, when patient lies in lithotomy, then usually the patient faces us. So this is going to be opposite to the direction in which we are. If the fetus occiput is in the right in our right direction, then we will say it is in the left, because we have to say everything with respect to the pelvis. Okay, because it will be the pelvis left, right? Now here in this position, see here, now this is pelvis, this is our right, but it will be the mother pelvis, it will be left, because mother is facing us, right? So directions will get opposite. Okay, so our right will become the pelvis left, or the mother's left, right? So now we know that posterior fontanelle or the occiput is in the left direction. So we will name this position left occiput interior, right? Posterior fontanelle was in the interior direction near the pubis, right? So occiput is also near the pubis. So now this is known as left occiput interior. Okay, so we have to take right or left with respect to the pelvis. We have to take interior and posterior with respect to the pelvis. Okay, so whether we are going to say right or left, it will be with respect to the pelvis, and whether we are going to say interior and posterior, it will be the with respect to the pelvis. So this first one is left occiput interior, and the next one in the PV is right occiput interior, and the one which is below is the right occiput transverse. Okay, so this is right occiput interior, because occiput is here interiorly in the right direction, and here the occiput is transverse, so it is right in the right side, so it is right occiput transverse. Okay, so usually in PV, whenever we do PV, the most common position which we get in the examination is left occiput transverse or left occiput interior. So what is the most common position? left occiput transverse or left occiput interior. Okay, the first one. So usually on the PV we feel posterior fontanelle, the triangular fontanelle. Okay, are you getting it? Because the most common position is left occiput transverse and left occiput interior. So when the occiput will be interior, which fontanelle will be filled? Posterior fontanelle, triangular fontanelle. Okay, okay. The most common mal position is right occiput posterior, and it is right occiput posterior. And the most common mal this was the most common mal position, right occiput posterior. And which is the most common mal presentation? It is breech presentation. Okay, frank breech, it is frank breech. So what is induction of labor? When we give certain drugs to start the labor pains. Okay, it is usually done at term, but now you know that there are some indication, for example diabetes, hypertension, in which due to some indication we have to induce early. Otherwise in most of the condition we induce the labor at term. Okay, so before inducing we should know what is the Bishop score of the patient, right? So what is the Bishop score means? The mnemonic for it is diethyl polycarbonate. Okay, so in the Bishop score cervix के 4 points हैं. ठीक है, number 1 is dilatation, which is the most important point, right? And second point is effacement, again, which is most important point. In the modified Bishop score, instead of effacement it is cervix length. Okay, diethyl, D stands for dilatation, E stands for effacement. In once again I am telling you, in the modified Bishop score, instead of effacement there is length. Diethyl poly, P stands for position. Okay, cervix का position क्या है? It is posterior. Posterior position is a bad position, bad status, right? Or it is interior, central, posterior, central or interior. Okay, then fourth point is carbonate, C stand for consistency. Consistency means either it is hard or it is soft or it is medium, right? Which is the consistency. So cervix के 4 points है. Once again, di stands for dilatation, effacement, dilatation and effacement, and then third point is position, whether the cervix interior, posterior or in the center. And the fourth point is consistency, whether it is hard, medium consistency or soft consistency. Soft consistency is in favor of delivery, right? So the fifth point is fetus head station. It is not about the cervix. Okay, it is not about the cervix, it is about the fetus head. Okay, okay. So now if the score is, now we will measure all these things and accordingly we give the score, right? Now dilatation जो है उसका score 0, 1, 2, 3 ऐसे देते हैं. इफेजमेंट का स्कोर कैसे देते हैं? 0, 1, 2, 3. डायलिटेशन, इफेजमेंट और स्टेशन, इन तीनों का 4 स्कोर्स होते हैं. 0, 1, 2, 3. ओके, 0, 1, 2, 3. ओके, 0, 1, 2, 3, राइट. और पोजीशन और कंसिस्टेंसी के 3 ही स्कोर होते हैं, 0, 1, 2. ठीक है. और अगर स्कोर इज मोर देन 6 देन द सर्विक्स इज फेवरेबल फॉर इंडक्शन. ठीक है. इफ द स्कोर इज मोर देन 6, सो हियर यू हैव टू ओनली रिमेंबर दिस टर्म, मोर देन 6. ठीक है. मोर देन 6 इज इन द फेवर फॉर इंडक्शन. ओके. Okay, now how we can induce a patient for labor pains? See, either we will give oxytocin drip or we will give prostaglandin. We can give beta all the prostaglandins, but we cannot give carboprost or PGF2 alpha. Okay, what are the induction drugs? Either we will give oxytocin or prostaglandins. In prostaglandin we can give all the prostaglandins except pgf2 alpha. बहुत बार आप लोग गलत कर रहे हो, प्लीज इसे इम्प्रूव कर लो. pgf2 अल्फा से इंडक्शन नहीं होती है. ठीक है, ठीक है. PGE2 other name is dinoprostone and PGE1 another name is misoprost or gemprost. ओके, ऑक्सीटोसिन ड्रिप जो है, अगर उसे ऑक्सीटोसिन, इफ यू आर नॉट गिविंग ऑक्सीटोसिन इन अ ड्रिप और एज इन्फ्यूजन, इफ वी गिव इट IV bolus, then this oxytocin cause hypotension. Okay, okay, got it. And the another drug which we can use for induction is mifepristone. What are the mechanical method of inductions? Though they are not used these days, you have to just remember the name. The number one name is very important. Just remember that. Intracervical balloon catheter. Intracervical balloon catheter. Okay. The fourth, the other methods are laminaria tent, sweeping of membrane, and ARM. So here I would like to tell you that ARM is contraindicated in heart diseases and IUD. ARM is contraindicated in heart diseases and IUD. Okay. Now let's study something about stages of labor. Surprisingly, the questions on stages of labor were wrong. See beta, when it is the first stage, when the true labor pain starts. It is the first stage. Up till 10 centimeter, cervix has to dilate. To expel the fetus, cervix has to dilate 10 centimeter. So from this, how the first stage starts? From true labor pains to 10 centimeter. Okay, so this first stage is divided into two stages. Number one is latent phase up till 5 centimeter. Okay, first it was up till 4 centimeter. Now it is up till, sorry, first it was up till 3 centimeter. Now it is up till 5 centimeter. Okay, so please don't get confused. We have got a question in INS set and NEET PG. In both exam we have come. Now it's our turn. Okay, now we will get this question. The latent phase starts from true labor pain to 5 centimeter of dilatation of the cervix. Okay, okay. What happens in the latent phase? In the latent phase, there is cervix effacement and dilatation both. Okay, mainly what all happens in the latent phase. In the latent phase, mainly there is cervix effacement and dilatation. Okay, cervix efface होता है और cervix dilate होता है. In nulliparous it is 12 centimeter, and in multigravida it is it is 12 hours, and in multigravida it is 8 hours. Okay, okay, once again, in nulliparous it is 12 hours and in multiparous it is 8 hours. ठीक है, 4 का टेबल है यहाँ पे. ठीक है, once again, the true labor, what is the first stage? From true labor pain up till the cervix dilate till 10 centimeter. Cervix is closed like this, right? Up till the cervix dilate like this 10 centimeter. This is first stage. And from where the first stage starts? From the true labor pains. First stage is divided into two phases. From true labor pain up till मिड तक 5 सेंटीमीटर तक लेटेंट फेज है. लेटेंट फेज में सर्विक्स इफेज होता है और डायलेट होता है. ठीक है, सो नल्लीपैरस में इट्स ड्यूरेशन इज 12 hours and in the multiparous its duration is 8 hours. It decreases. Okay, the active phases from more than 5 centimeter to 10 centimeter cervix dilation. Here the dilatation occurs, and if descent of the fetal head occur, okay, station comes down down down. Okay, so what is the speed of dilatation in both nulliparous and multiparous? It is 1 centimeter per hour. And what is the speed of descent? 1 centimeter per hour, or 2 centi in the nulliparous, and in the multiparous it is 2 centimeter per hour. Okay, once again, the active phase is May. What happens in active phase? Dilatation and descent happens. Dilatation of the cervix and descent of the fetal head occurs. Okay, so what is the speed of the dilatation? 1 centimeter per hour. So what will be the speed? कहाँ से कहाँ आना है? 5 से 10 जाना है, तो 5 hours का हो गया ना एक्टिव फेज, राइट. And what is the speed of the descent in nulliparous? It is descent of the head is his descent का speed क्या है? 1 centimeter per hour in nulliparous and 2 centimeter per hour in the multiparous. Okay. Now what is protracted active phase? Protracted means slow हो गया, ठीक है, जिस स्पीड पे होना चाहिए था नहीं हो रहा. 1 centimeter per hour से डायलेट नहीं हो रहा है cervix. It is like half centimeter per hour like this. Okay, so what you are going to do when there is slowing a protracted active phase? Then we are going to rule out CPD. Okay, or we will rule out occipito-posterior position. Only two things we will do if there is protracted active phase. Number one, we will rule out CPD. Fetus descent नहीं हो रहा है, right? Descent क्यों नहीं हो रहा है? क्योंकि pelvis छोटा पड़ रहा है, because pelvis is less in diameter, dimensions is being, so there is cephalopelvic disproportion. So we will rule out CPD, or we will rule out the position, because occipito-posterior में rotation होना होता है, तो it takes time. Okay, so we will rule out these two things. What is active phase? Arrest. Arrest means the progress has stopped. What does the word arrest means? Arrest means the progress has stopped. Okay, so in spite of good contraction, if there is no descent or dilatation, so contractions are present, good contractions are present. In spite of the good contraction, if there is no descent, descent or no dilatation, cervix dilatation for 4 hours, it means the active phase is stopped. Arrest means stop, protracted means slow down. Okay, so if there is arrest, then we will do the cesarean. Okay, now let us see what is second stage. Second stage means after full dilatation of the cervix to expulsion of the fetus. Okay, so in the nulliparous it is, yes, in the nulliparous it is 1 hour, and if it is prolonged, when we will say it is prolonged second stage, at 2 hour, and it is arrest, to say arrest we have to add +1. ओके, प्रोलॉन्ग कहने के लिए हम उसको डबल कर देंगे, ठीक है, क्योंकि नलीपैरस में एवरेज 1 आवर की होती है. अगर हमने उसे प्रोलॉन्ग बोलना है तो हम बोलेंगे, कब बोलेंगे कि प्रोलॉन्ग सेकेंड स्टेज हो गई? जब 2 घंटे हो गए पेशेंट को और फिर भी एक्सपेल नहीं हुआ फीटस, तो वी विल से दैट इट इज अ प्रोलॉन्ग सेकेंड स्टेज. ठीक है, राइट, गॉट इट, ठीक है. एंड इन द मल्टीपैरस द एवरेज ड्यूरेशन ऑफ द सेकेंड स्टेज इज, yes, in the average duration of the second stage in the multiparous is 30 minutes, and we will say it prolonged to you have not to learn the prolonged diameters, you have just you are going to double it, right? To say it prolonged, on you have to double the duration of the average. So in average, the duration in the multiparesis of the second stage is 30 minutes. To say it prolonged, the duration becomes 1 hour. Okay. So what is the cause of prolonged latent phase? Now latent phase was a part of first stage, right? First stage was divided into two parts, the latent phase and active phase. Active phase में हमने पढ़ लिया था जब when there is protraction or arrest, then we have to, in the arrest we have to do cesarean, and when there is protraction we have to rule out two things, CPD and occiput posterior. And when there is prolonged latent phase, then we have to rule out two things, either it is false labor or it is poor cervical condition. So how we will rule out? We are going to give rest and sedation to the patient. We will give the rest and sedation to the patient, and thereby we will रूल आउट. अगर रेस्ट और सेडेशन देने के बाद उसको पेन्स नहीं जाती हैं तो इट मीन्स दे आर ट्रू लेबर पेन्स. ठीक है. सो देन वी शुड इंड्यूस इट. इस पे क्वेश्चन नहीं आया पर आ सकता है. मान लीजिए हमारे पास एक पेशेंट आई, 1 सेंटीमीटर डायलेटेड है, उसको 17-18 घंटे से पेन्स हो रही हैं थोड़ी थोड़ी, और हमने उसको रूल आउट करना है ये फॉल्स लेबर पेन्स है कि ट्रू लेबर पेन्स है. हमने उसे सेडेशन दिया. अगर पेन्स चली गई तो वो फॉल्स लेबर पेन्स थी. अगर फिर भी उसको पेन्स हो रही हैं, सो इट मीन्स इट इज अ ट्रू लेबर पेन्स. नाउ व्हाट वी विल डू? नाउ वी विल इंड्यूस. Okay, and now we will induce because it is now a poor cervical condition, right? And what are the causes of prolonged second stage? Either it is CPD or it is impaired expulsive efforts. Either it is CPD or it is impaired expulsive efforts. सेकेंड स्टेज में पहुंचने के बाद भी बच्चा नहीं आ रहा, उसके क्या कॉजेज होंगे? या तो CPD है, ठीक है, या पेशेंट के एफर्ट्स इतने अच्छे नहीं हैं, एक्सपेल पेशेंट अच्छे से नहीं कर रहा. ठीक है. सो उस केस, CPD केस में हम क्या करेंगे? मैनेजमेंट क्या होती है प्रोलॉन्ग सेकेंड स्टेज की? अगर तो स्टेशन, अब यहाँ पे हम देखेंगे स्टेशन, अगर तो स्टेशन +2 है तो हम उस पर फोर्सेप वैक्यूम लगाएंगे, और अगर स्टेशन +2 नहीं है तो हम उसका सिजेरियन करेंगे. ठीक है. सो हाउ वी आर गोइंग टू मैनेज सेकेंड स्टेज? वी विल मैनेज द सेकेंड स्टेज डिपेंडिंग ऑन स्टेशन. सो इट डिपेंड्स ऑन द स्टेशन of the fetal head. If the station is +2, then we will do it by, manage it by forceps or vacuum, and if it is above +2, then we will do cesarean. Okay. Now what is the mechanism? What all movements occur in the labor? First of all, engagement occurs. The biparietal diameter, it crosses, when it crosses the pelvis inlet, it is known as engagement. Then descent occur. ठीक है. Fetal head, when it crosses, now if this is pelvis and this is biparietal diameter, when it crosses the inlet, then we will say it is the engagement has occurred. Okay. Then descent, and with the descent the flexion occurs. Now when flexion occurs, then which diameter becomes a diameter? Which diameter? We face suboccipitobregmatic. So when full flexion is there, then which diameter is felt on PV? Suboccipitobregmatic. Then at the level of the ischial spine, internal rotation occurs. After what? Internal rotation occurs by 1/8. Okay. So then crowning occurs, then head extend like this. ठीक है. And then it delivers, and then restitution. Now once again I am telling you, suppose this is fetal head. Okay. First of all, the biparietal transverse diameter. This is a transverse diameter. See, this is the transverse diameter, right? So now when this enters the pelvis, biparietal, it is engagement, then it flexes. Now the diameter becomes suboccipitobregmatic. Okay, now this is, now see, now it becomes suboxygen. Now as it goes, the ischial spine, the internal rotation occurs. Now this my fetal head will move 1/8 like this. Now this will deliver by extension, and now this will restitution will occur, and then external rotation. External rotation is nothing but internal rotation of the shoulders. Okay, now how you will remember all these name in the series? We need a mnemonic, right? Every decent female in career employs rich and expensive maids. Okay, once again, every decent female in career employs rich and expensive maids. So what does E stands for engagement, decent stands for descent, female stands for flexion, in stands for internal rotation, career stands for crowning, employee stand for extension, rich stand for extension, restitution, and expensive stand for external rotation, and for maids it is nothing. Okay, now let us see manage of prolonged stage. I already told you it depends on station, right? It and if the station is less than +2, then we are going to do cesarean. Okay, and if there is capet and molding also, then also there are high chances that fetal distress will be there, and we will do cesarean. Okay, now there are some WHO guidelines for the second stage. First of all, no routine episiotomy, and next number second is no preference to lithotomy position. Okay, in which position we will do the delivery? In whatever position the yes, in whatever position the patient wants. So lithotomy position is not essential. Modified Ritson maneuver is used to deliver the head of the baby. We can give perineal compression. Okay, and recent WHO guidelines says that flexion attitude should be maintained. Now let us study about the partograph. Okay, so what is what all do we do on the partograph? See, in the first of all, in the above page of the partograph, we write the GPL status, LMP, when are the labor pains started, all the history relevant things. Okay, in first and foremost on the above segment we write the history portion, and the second segment is all the fetal heart rate. So fetal heart rate is to be checked every 30 minutes. Okay, fetal heart rate in a laboring patient we have to check every 30 minutes, and then we have to label it on the partograph. Okay, then third segment is about molding is present or not. Okay, and the fourth section is very important, and the cervicograph portion, in which we have to now write here cervix dilatation and descent. Okay, which two cervical cervical parameters we plot on the partograph or the cervicograph? Dilatation and descent. Don't please write effacement. Okay, two uh, parameters which we plot on the graph of the partograph or the cervicograph are the dilatation and descent. Okay, so we start the graph from 4 centimeter, right? So on the y-axis here is the parameters 1 2 3 4 5 6 7 8 9 10. These are the cervix parameter. Okay, and on the x-axis here it is time. Okay, so every one small square is for yes, this small one square is for half hour. ओके, अब हम इसको समझेंगे कि अगर तो हर 1 घंटे में 1 सेंटीमीटर डायलेट होगी, ठीक है, सो द ग्राफ विल बी ऑन द लेफ्ट ऑफ द अलर्ट लाइन, ठीक है। तो ग्राफ इस पोजीशन में रहेगा, ठीक है। सो एवरी स्मॉल स्क्वायर इज, सो एवरी स्मॉल स्क्वायर इज हाफ आवर, सो 2 स्क्वेयर्स के बाद 1 घंटा हो जाता है, ठीक है। तो ये अलर्ट लाइन ऐसे बनाई गई है कि 1 सेंटीमीटर और डायलेटेशन अगर होगी, जैसे मान लो हमने 4 से स्टार्ट किया इसको, सी अगर ये 1 सेंटीमीटर पर आवर डायलेट होगी तो ये इधर रहेगा। एंड अगर ये लेट हो गई, मान लो 1 सेंटीमीटर 2 आवर्स पे हुआ, तो ये इधर आ जाएगा, ठीक है। नीचे आ जाएगी ना लाइन, टाइम ज़्यादा लग रहा है, ठीक है। नीचे आ जाएगी ना लाइन तो वो इधर आ जाएगी, ठीक है। और इसी तरह से डिसेंट हमें यहाँ पे नीचे 4 से नीचे 4 3 2 1 में यहाँ पे हमें डिसेंट ऑफ हेड लेवल करना होता है। अलर्ट लाइन एंड एक्शन लाइन के बीच में 4 आवर्स का गैप होता है। दिस गैप इज ऑफ 4 आवर्स, ओके, 4 आवर्स, ठीक है। सो हमने अरेस्ट ऑफ एक्टिव फेज में क्या पढ़ा था, 4 आवर्स के बीच में अगर प्रोग्रेस नहीं हुई तो हम उसका सिजेरियन करेंगे, पढ़ा था ना हमने अरेस्ट ऑफ एक्टिव फेज। अगर 4 आवर्स तक कोई प्रोग्रेस नहीं हुई, सो अगर 4 आवर्स तक कोई प्रोग्रेस नहीं हुई तो वो एक्शन लाइन को टच कर जाएगा, ठीक है। सो व्हाट इज द डिस्टेंस बिटवीन द अलर्ट लाइन एंड एक्शन लाइन, 4 आवर्स। अगर 4 आवर्स तक कोई प्रोग्रेस नहीं होगी तो वो एक्शन लाइन को टच कर जाएगा, ठीक है, राइट साइड में आता जाएगा। क्योंकि अगर लेट डायलेटेशन होगी या नहीं होगी डायलेटेशन तो वो एक्शन लाइन, तो वो नीचे आती जाएगी। टाइम ज़्यादा लग रहा है ना डायलेट होने में, तो वो जो हमारा सर्वाइकोग्राफ हम प्लॉट कर रहे हैं, वो लाइन जो हम प्लॉट कर रहे हैं पेशेंट की, वो नीचे आती जाएगी, वाई एक्स एक्सिस की तरफ आती जाएगी ना, टाइम एक्स एक्सिस पे, तो वो नीचे आती जाएगी तो वो राइट साइड होती जाएगी। और अगर वो 1 सेंटीमीटर पर आवर डायलेट होती जा रही है तो वो लेफ्ट की तरफ रहेगी, ठीक है, ओके। चलिए नेक्स्ट है नाउ द ब्रीच, ब्रीच प्रेजेंटेशन के बारे में। मोस्ट कॉमन माल प्रेजेंटेशन इज ब्रीच प्रेजेंटेशन। ब्रीच प्रेजेंटेशन इज ऑफ 2 टाइप्स, कंप्लीट ब्रीच जिसमें ऑल द होल द fetus is in flex position, ठीक है। when I'm saying you whole the fetus is in flex position, so it means and head and hip and knee joint, okay. So now you can see here the hip are flexed and the legs are also flexed. So this is the complete breech and flex breech. Here hips and knees both are flexed, and on the PV what we will feel? These things, what are these things? Genitals and feet. We will feel both. What we will feel? We will feel genitals and feet. In the incomplete breech, the knees are not flexed, but the hip joint is flexed. So what we will feel? On the PV we will feel only genitals, okay. And this type of incomplete breech is known as frank breech, and it is the most common breech, okay. Please remember that the frank breech is the most common breech in which the knee joint are extended or the legs are extended, okay. And on the PV we feel only genitals, okay. So what is the most common etiology of the breech is prematurity is the most common etiology of the breech, okay. At 28 weeks 30% of the fetuses are breech. So what is the most common etiology is prematurity, okay. At term only 3% of the fetuses are left, breach. So what is the incidence of the breach at term? Please remember this percentage. It has come once in the exams. Okay, five. It's a 5-year PYQ. At term, there are only 3% of the all the pregnancies are breach. Okay, and at 28 weeks 30% are breach. So you know that at till term the number of the breach they decreases and they get left only up till 3%. Okay, please remember this percentage, 3%. Okay, they do come in exam. And what is the most common etiology for the breach? Prematurity. अगर premature होगा तो फिर breach होगा. ठीक है, ज़्यादा चांसेस हैं उसके ब्रीच होने के, क्योंकि एट 28 वीक्स 30% ऑफ फीटसेस आर ब्रीच. एज द एज एडवांसेस द फीटस चेंज देयर पोजीशन एंड एट टर्म ओनली 3% आर लेफ्ट ब्रीच. ओके, अदर व्हाट आर द अदर फैक्टर्स? What are the other factors? Or agar it is a placenta previa, then again breech position can occur if there is any fetal anomaly or maternal uterine anomaly, or these all are the other factors. Okay, but most common is prematurity. How we are going to manage? I don't know why we have this myth that primary breech should be done cesarean. Please please remove this myth that primary breech should be done cesarean. No, this is a myth. Breech should be done delivery only by trained obstetrician who is expert in doing the breech delivery. That's it. No primary multi-para breech. No. Okay, so breech will be done normal only by a trained obstetrician who is expert in doing breech delivery. And the institute in which the breech delivery is being done and the institute in which the breech delivery is done, there the facility of emergency cesarean is available. Okay, so breech will be done normally only and only if the yes, the delivery is being done by the trained obstetrician and the emergency cesarean facility if needed is available. Okay, now there are 3 methods by which the breech can be delivered. Number 1 is breech extraction, in which we keep on in what is breech extraction? There are 3 methods of breech normal delivery, breech vaginal delivery. Number 1 is breech extraction, where we keep on manipulating the fetus. Okay, the second is breech assisted, in which we don't touch the fetus before umbilicus is delivered. Okay, and spontaneous, everything happens, is a spontaneous expulsion of fetus. So the most recommended is breech assisted. Okay, the most recommended is breech assisted. ब्रीच एक्सट्रैक्शन मतलब हम शुरू से उसको करे जा रहे हैं, आजा आजा खींचे जा रहे हैं, पुल किए जा रहे हैं. ब्रीच असिस्टेड में हम उसको अम्बलाइकस तक टच नहीं करते, बाद में उसको हम मैन्यूवर्स करते हैं एंड टच भी नहीं करते जब तक अम्बलाइकस डिलीवर नहीं होती. स्पॉन्टेनियस में सब कुछ अपने आप हो जाता है. ठीक है, सो मोस्ट रिकमेंडेड इज ब्रीच असिस्टेड. ओके, नाउ let me show you the maneuvers. See, this is the maneuver for after coming head. So here we are applying Piper's forceps. Okay, this is most recommended method for the after coming head, Piper's forceps. This is the pinard maneuver for the extended legs, pinard maneuver. So, and this is the Lovesitt maneuver for shoulder. ठीक है, and the in which we make the rotate the fetus in a C shape is the burn mesh Marshall maneuver. It is again for the head of the fetus, and in which we give shoulder traction and malar flexion. This is Mauritius Smiley White maneuver. Okay, now let us see face presentation. when the face is presenting, then there can be two positions, manto anterior and manto posterior. Okay, manto interior and manto posterior. If the mantus, the denominator, is interior, then it is known as manto interior. And if the denominator is mentum is chin, mentum is posterior, then it is known as mento posterior. In mento interior, the diameter is small, it is submentobrachmatic. Okay, it is submentobrachmatic. And in the mento posterior, the diameter is large, it is mento vertical, 14 centimeter. So here we have to do cesarean. Okay, in every brow presentation we will do cesarean. Okay, so this class of part 5 ends here only. We will soon join you again. Okay, so all the guys you are watching, soon I will give you the another segment of this video. Okay.